We shall go on to our next speaker, Dr. Parthapratim Datta, who is a Senior Consultant, Department of Uvea and Intraocular Inflammation, Shankar Nethralaya, Chennai, with great work in the field of uvea, with lot of awards and attributes to his person. He is going to be dealing with how to investigate in a case of anterior uveitis clinical lab correlations. On to you, doctor.
Good evening, friends. I hope my slides are visible and you can hear me. At the outset, I would like to thank Dr. Chitra Ramamurthy and team ARC for inviting me to this symposium. I have been asked to speak on how to investigate a case of anterior uveitis clinical lab correlation for 8 minutes. I would try to give an overview of the topic and discuss mainly the basic principles of clinical lab correlation for the ophthalmologist. In case you have any query, please feel free to mail me if it remains unanswered. Let me start the discussion with the most valuable and important test in anterior uveitis. It is the microscopy, which can be used as the most important tool in the evaluation of a case of anterior uveitis. No, I'm not talking about this microscope. I'm talking about the microscope which can give up to 20 to 40x magnification and can help us to see the inflammatory cells, can quantify the inflammation, and can provide overview of the inflamed structures. I think we are the only subspecialties in the medicine who can observe the ongoing inflammation with our naked eye. So now going to this, I just want to touch this important topic that identifying the clinical phenotype of the uveitis is the most important step. But you have to remember, always think of common causes. Like if you see the fibrinous content in anterior uveitis, think of HLA-B27. Corneal opacity with iris atrophy, think of viruses, most commonly the herpes viruses. Mutton fat capes and iris nodule, rule out TB and sarcoidosis, and stellate capes and loss of iris pattern, think of Fuchs uveitis. Now, when we talk about clinical pattern recognition, then before doing laboratory investigation, you can actually differentiate between the granulomatous and non-granulomatous. But as the previous speakers have mentioned, that this kind of differentiation or this Wood classification have some downside, because this clinical phenotype sometimes overlaps, and sometimes granulomatous entity like sarcoid can present with a non-granulomatous picture. But overall, the Wood's classification is a very good way to start your clinical pattern recognition. Now, when you, with the help of laboratory test, you search for systemic rheumatic diseases, you have to remember three important rules. Rule number one, no single test is diagnostic and most of them are non-specific. You have to remember that rheumatoid factor, antinuclear antibody, these are the tests can be found positive even in the normal population, normal healthy adults. So you have to correlate them with the clinical picture. The next is HLA-B51. So many of us, when we suspect, we see a mobile hypopia and we order for HLA-B51. You have to remember that HLA-B51 does not rule in or rule out Behçet disease. And that's why it has not been added in the Behçet disease classification. The second rule is, whenever in doubt, do refer to rheumatologist. One classical example is ANA. Usually 1:60 dilution is very important, and more than that, we take it as a very seriously. But when you are in doubt, there is the ANA dilution is less than 1:40. In that case, don't hesitate. You have to send this patient to rheumatologist. Overall, when you are suspecting systemic rheumatic disease or some autoimmune disease, you have to refer this patient to your rheumatologist friend. Last but very important point is that a biomarker can be positive in later course of the disease. It can be HLA-B27. You are thinking that it should be HLA-B27, but the marker is negative. You have to wait. It can be positive after maybe a variable period of 3 to 4 years. Similarly, ANCA, it has been seen that the in 30% of the patients, the ANCA test is negative till the later part of the disease. So it is very important to understand that this biomarker can be positive after a certain period of time. When it comes to investigating for the granulomatous uveitis, usually I do want to test, because positive or negative, it aids in the diagnosis. How? Because negative, the energy to the tuberculin protein is also important sign of sarcoidosis. So even if a MONTU test is negative, it helps in helps you in clinical decision making. I always prefer to do HRCT chest because it's superior to chest X-ray, and it can actually delineate the lymphadenopathy much clearer way and helpful in both TB and sarcoidosis. Interferon gamma release assay we don't do always, and this two sets twin enzymes actually indicates the granulomar load. And the liver function test we always do, because sometimes in sarcoidosis it can be raised. Also, if you are planning to start the ATT, you have a baseline value. And in case of any kind of methotrexate or immunosuppressive, you need a liver function test. PCR for Mycobacterium tuberculosis, for those here, it's subject to availability in your hospital, and it depends on the cases. In challenging cases, you should perform that. So next speaker will discuss the PCR in detail. Now, coming to the infectious disease and the serological test, I want to give one advice that don't use serological test alone to diagnose infections. This is not applicable to syphilis and HIV. And one step ahead, I will suggest better you should do syphilis, HIV, and rule out these two serology in every patient. But for the other entities, as you can see here, ELISA TB is now banned in India. One should not use it at all. The other test, you have to remember, this reflects the presence of the ubiquitous organism. Let me show you two studies. If you see here, those who diagnosed do a torch titer and diagnose it as a interior uveitis due to herpes viruses, you have to remember that there are studies which has showed that the 92% of the humans shed HSV-1 DNA from their tears. Over 93% human autopsy revealed the presence of herpes simplex virus DNA in their trigeminal ganglion. So in absence of clinical signs, it's better not to diagnose a case only on the basis of the serological test. Now, this is, I always highlight that Fisherman's Guide to the laboratory workup in uveitis. You have to always remember that rule number 1 is investigation in uveitis, though it is Fisherman's Guides, not a fishing expedition. Don't investigate a case of uveitis aimlessly. You have to correlate. You cannot catch every investigation. You see a case and order everything. This is not done in uveitis. So number 2, a little bait catches a large fish. This is very important, as many people have discussed that the hypopyon can be a rare presentation. From my experience, I can tell this: the leukemia can be the initial manifestation and sometimes the presenting signs of the relapse. So looking at the simple signs like the pallor and other subtle signs like the weight loss, and a simple 200 rupees blood test, the peripheral blood smear, can clinch the diagnosis of such a hematological malignancy. Also keep in mind when you are examining or dealing with a patient of uveitis in extremes of age. The number 3, don't fish for the things you don't know how to cook. If you're not sure about that laboratory marker, don't do it. For example, you have seen a case of anterior uveitis, 30 years old, no systemic complaints or sign, but you have advised ANCA. Now, if it comes positive, you will create lab-induced diagnostic challenge for yourself. In absence of systemic signs, association between small vessel vasculitis and anterior uveitis is very, very negligible. So don't try to catch a fish if you don't know how to cook it. Now, I'll just finish with this algorithm that anterior uveitis, from clinic to laboratory, you should determine the predominant site of inflammation. You have to rule out that the inflammation is not there in the posterior segment or in other part of the eye. Then you have to decode the clinical phenotypes. Many speakers have already highlighted that how to do a perfect slit lamp examination and find out the clinical signs. Take a meticulous history. Don't take the history before, even if you are taking after examining the patient, take again, sit with the patient and ask for specific systemic signs and look for them. I'll just show a approach. how to approach a case of hypopyon uveitis in your clinic. I'll just give 3 most common scenario in our day-to-day practice. The first, the patient can have actually present with severe fibrinous reaction, non-granulomatous anterior uveitis. Patient can give history of lower backache, and it can be recurrent attack, like Dr. Somashila mentioned, that it can be bilaterally alternating, not simultaneously bilateral most of the time. So in such scenario, your job is easy. Now you know that you have to order HLA-B27. You can order excess sacroiliac joint. You know that it can be a case of HLA-B27. The second scenario, if it is a case of panuveitis, the mobile hypopyon, the patient, or you ask the patient and patient gives the history of recurrent oral and genital ulcer, you should send the patient to rheumatologist and can actually advise HLA-B51. Now, number 3 scenario, if you see granulomatous panuveitis, the patient gives you history of hospitalization, the known patient of diabetes mellitus gives a septic foci like a big abscess or boil. So in that case, you know that you have to send the blood and urine for culture. You have to refer to your vitreoretinal colleague for vitreous biopsy. It can be a case of endogenous endophthalmitis. Thank you.
Beautiful talk, Dr. Partha. And Dr. Mudit, do you have any question to ask?
Yes. So very nice talk, Dr. Partha. Just few questions. The first question is something which is so common in everybody's mind. This is regarding one of the most common diagnostic thought process or dilemmas which we face. How much of importance do you give to MON2 in your set of investigations, and what would you prefer between a MON2 or a quantiferon TB gold when it comes to investigating these cases?
Yeah, well, very nice question, Mudit. MON2 I do routinely, and I give preferences to MON2 reading of more than 15 mm, but it's the clinical phenotype which matters most to me. So it's not that all patient will come to me, I'll advise MON2 test. So as I mentioned, that first is the clinical pattern recognition, and then I go for that.
And between MON2 and QTB? Between MON2 and quantiferon?
QTB, sometimes I am not sure. I am thinking a patient looks like a tubercular uveitis. MON2 test was done elsewhere. The patient was on high dose of steroid. I am not sure, convinced. That time I do quantiferon, but not.
Yeah, I agree with. I agree with you. The same way we also practice.
Thank you,
Dr. JB sir. What are your thoughts on this? Sir, you are muted.
Because I do both. Because sometimes the MON2 negative quantiferon TB gold test is positive. So my clinical phenotypes is any of this diagnostic test is positive, I go ahead with the anti-TB treatment. So my clinical diagnosis is first, but I do order both. So even quantiferon TB gold is negative, MON2 can be positive.
Dr. Vaishali, Dr. Avinash, any thoughts on this?
I think I just make up my mind depending on the clinical presentation that I have to give ATT, and I do these tests just to save my skin, that if they come positive, I'm justified in giving. You know, that's how it works. But
Dr. Avinash?
Phenotype is the key.
I don't think so I have anything else, because that's a fantastic presentation what Partho had made. And one point which I would still like to highlight in his presentation was, maybe relating to the fishing expedition, what he said. If you don't get fish in the first time you go to the sea, don't, you should not get disheartened. Go on fishing. Sometimes you'll get, the big fish later on. And that's what he had beautifully mentioned. The first time you might be negative, but later on, it doesn't mean that for lifelong he's negative.
Thanks, sir. I'll add the 4th point.
Yeah.
I think it's also very important not to label the diagnosis, because diagnosis keeps on changing from time to time. And in places where we have fellows, if God forbid you have written BKH, which might be TB, they always say it's a known case of BKH. So your mind is already in different directions. So that's very important, never to fall in love with your diagnosis.
Very insightful.
Thank you. Thank you. That was a lovely talk and discussion.